Good evening, everybody. Thank you for joining our discussion on macrophage activation syndrome. I'm Dr. Alexei Grom, a pediatric rheumatologist at the Cincinnati Children's Hospital Medical Center. And I'm joined by Dr. Scott Canna, who is also a pediatric rheumatologist at the Children's Hospital of Philadelphia. Over the next 45 minutes, we would like to discuss macrophage activation syndrome that is seen in rheumatology. We will briefly go over the pathogenesis, diagnosis, and the management of this life-threatening complication. I would like to start with some brief definitions of hemophagocytic lymphohistiocytosis. In general, immune system is designed to eliminate infected or malignant cells. In HLH, appropriate initiation but defective termination of the immune response may lead to a cytokine storm, infiltration of the tissue with inflammatory cells, and tissue damage. HLH can occur as a primary genetic disorder, or it can present as a complication of infection, malignancy, or a rheumatic disease. It also can be triggered by certain therapeutic interventions that we often use in our clinic, and that includes CAR T-cell therapy. Distinguishing between these clinical scenarios sometimes may present a significant challenge. If you look at the contemporary classification of hemophagocytic disorders, it distinguishes primary and secondary HLH. Primary HLH is a constellation of rare autosomal recessive disorders affecting mainly cytotoxic T-cell pathway. Some patients who have defects in the inflammasome function may also develop HLH and are also classified in this category. These patients typically present with the first symptoms of HLH very early in life. Their clinical course is usually very severe, and most of these patients will require bone marrow transplantation as a definitive treatment. Secondary HLH can occur at any age. Many of these patients actually do have hypomorphic heterozygous variants in the genes associated with primary HLH. And typically in these patients, an episode of HLH is triggered by either an overwhelming antigenic stimulus. It could be infection, could be malignancy, could be autoimmunity, or it could be triggered by an episode of hyperinflammation associated with the underlying autoinflammatory disease. Many of these patients have a substantial risk for recurrence. Now, this slide summarizes our current understanding of the pathophysiology of primary genetic HLH. In an otherwise healthy individual, excessive activation of CD8 cells, typically driven by infection, would trigger activation of negative regulatory feedback loops, including the one shown here. And in this particular loop, we see that CD8 cells may kill antigen-presenting cells. In this example, we are looking at a dendritic cell. And this, in turn, will decrease antigen presentation and will prevent further activation of T cells. So this is a very important immunoregulatory loop that prevents excessive activation of cytotoxic CD8 cells. Loss of this particular regulatory loop will lead to uncontrolled expansion of highly activated CD8 cells, producing massive amounts of interferon gamma. Interferon gamma is a cytokine that is very well known for its ability to stimulate macrophages, and this sort of massive stimulation of macrophages with this cytokine leads to their expansion. They secrete many other pro-inflammatory cytokines, and in fact, many of the clinical features of HLH could be directly linked to the abnormal behavior of these cells. The primary or the upstream event, however, is T-cell driven. So the question is whether this particular mechanism is also relevant to patients with secondary HLH. When secondary HLH occurs in a setting of inflammatory rheumatic disease, we typically prefer to use the term macrophage activation syndrome. In our field, the term macrophage activation syndrome specifically refers to a clinical phenomenon caused by excessive activation and proliferation of T cells and well-differentiated non-neoplastic macrophages. And as in primary HLH, these macrophages exhibit hemophagocytic activity, and this is shown on the right side of this slide. The expansion of the cells leads to a massive systemic inflammatory response, typically associated with 4 cardinal features: cytopenias, liver dysfunction, coagulopathy that looks very much like disseminated intravascular coagulation, and extreme hyperferritinemia. In pediatric rheumatology, certainly MAS occurs by far most frequently in systemic form of juvenile idiopathic arthritis. Because lupus and Kawasaki disease are 2 other conditions where we see this complication somewhat more frequently. It's a life-threatening complication, and the mortality rate may reach 20% even in the best centers. Now, what do we know about the histopathology of MAS? If you look at the inflammatory lesions in these patients, the inflammatory infiltrate actually is quite distinct. It consists predominantly of cytotoxic CD8 cells and CD163 positive highly activated histiocytes. And this feature is certainly very, very similar to what might be seen in primary HLH. And all these cells produce massive amounts of inflammatory cytokines, both T cell derived as well as monocyte and macrophage derived. In this cytokine storm, interferon gamma is now emerging as the pivotal cytokine. In general, in active systemic juvenile idiopathic arthritis without signs of MAS, we typically do not see much evidence of increased interferon gamma activity. However, with the emergence of the clinical features of macrophage activation syndrome, we start seeing massive activation of the interferon-induced signaling pathways. So in this example, in this figure, we're looking at the interferon-induced signaling. Interferon gamma binds to its own receptor. This binding leads to activation of JAKs, as well as molecule called STAT1. STAT1 gets phosphorylated, and this phosphorylated STAT1 gets translocated into the nucleus, where it activates numerous genes that are very, very important in inflammation, and that triggers, amplifies the inflammatory response. One of these genes encodes a molecule called CXCL9. It's a chemokine that is induced almost exclusively by interferon gamma. And in many translational studies in human, this particular biomarker has been successfully used as a very accurate measure of tissue activity of interferon gamma. So in this particular study, we looked at the correlation between the levels of interferon gamma and laboratory features of macrophage activation syndrome. In this example, we're looking at the serum levels of ferritin. In a cross-sectional study of patients with active systemic sJIA with or without MAS. Black triangles indicate patients with active systemic sJIA without MAS. Red triangles indicate patients with active macrophage activation syndrome. And what I'm trying to show here is that in active systemic sJIA without MAS, we see very little evidence of interferon gamma activity and essentially normal levels of CXCL9. However, if you focus your attention on the red triangles, those are patients with active MAS, the levels of interferon gamma go up. And we see a pretty strong correlation between serum level of ferritin and serum level of CXCL9, suggesting that there is a clear relationship between laboratory features of MAS and the activity of this cytokine. If we look at other cytokines that are important in many inflammatory responses, in this example, we are looking at IL-6 and TNF-alpha, we do not see similar correlations. Another interesting observation is that, recent observation is that bone marrow of hemophagocytic macrophages in patients with sJIA-associated macrophage activation syndrome actually could be distinguished from other macrophages by very strong interferon-induced signature, suggesting that at least partially these cells are indeed driven by interferon gamma. And another recent observation is that monocyte from systemic JIA patients typically exhibit exaggerated reactivity to interferon gamma. So combined all these observations, all these translational studies led to this view of what might be happening in macrophage activation syndrome. As in primary HLH, we believe that the central feature of this clinical phenomenon is this uncontrolled expansion of cytolytic CD8 cells. They are highly activated. They secrete massive amounts of interferon gamma. Interferon gamma stimulates monocytes and macrophages that become highly activated. Some of them become hemophagocytic, and they also start to secrete many pro-inflammatory cytokines. Some of them actually have the ability to further stimulate cytotoxic CD8 cells. This is certainly true for IL-18, and this eventually leads to this vicious cycle and escalating production of cytokines, culminating as a sort of a cytokine storm. And again, lots of translational studies suggest that interferon gamma is the critical player in this cytokine storm. So what's upstream of this uncontrolled expansion of cytotoxic CD8 cells in macrophage activation syndrome is not clear. We remember we discussed the role for defective killing of antigen-presenting cells in primary HLH. We believe that some of it is happening in macrophage activation syndrome. Patients with systemic JIA typically do have deficient NK cell function. But what we think is more important here is that the inflammatory milieu of systemic juvenile idiopathic arthritis could be distinguished by strikingly high levels of IL-18. And if you remember, IL-18 was initially described as a factor that induces production of interferon gamma by cytolytic CD8 cells and natural killer cells. And perhaps this feature, combined with the fact that monocytes and macrophages in systemic JIA exhibit hyperreactivity to interferon gamma, the combination of these two features may explain why we see macrophage activation syndrome in systemic JIA much more frequently compared to other rheumatic diseases. Now, I briefly would like to discuss this interesting concept that is gaining popularity. It is the threshold model of macrophage MAS development in patients with various inflammatory conditions. The idea here is that it's the combination of genetics and environmental factors, environmental triggers, that determines the overall risk for the development of macrophage activation syndrome. If the genetic background is very strong, then just a common infection could be sufficient to trigger a full-blown macrophage activation syndrome. If the genetic component, however, is relatively weak, it will need to be combined either with the inflammatory milieu of the underlying rheumatic condition or a massive infection. And that combination of those two events would trigger a full-blown macrophage activation syndrome. As you can see on this picture, macrophage activation syndrome presenting as a complication of rheumatic diseases is somewhere in the middle of this spectrum. Now, briefly, I would like to discuss some of the clinical aspects of macrophage activation syndrome. This syndrome typically have an acute onset with a high risk for rapid life-threatening deterioration. In about 50% of the cases, we can identify a clear trigger. Usually it's infections, and among the infections, EBV and CMV are most commonly reported. And certainly these infections need to be treated. Occasionally, we believe some drug manipulations can trigger MAS as well, although I'm not convinced that it's the case. In many cases, a flare or MAS is actually triggered by the flare of underlying rheumatic disease. These patients become acutely ill. They develop persistent fevers, which actually are quite different in their pattern from the spiking fevers of the underlying systemic juvenile idiopathic arthritis. These patients develop impressive lymphadenopathy, hepatosplenomegaly. Many of these patients develop hemorrhagic rash. Typically, they start with easy bruising that may progress to purpuric lesions and eventually very bizarre bleeding from mucosal surfaces, particularly from the gastrointestinal tract. Many of these patients develop mental status changes. Some progress to seizures, and in those patients, typically, if we perform a spinal tap, we will see CSF pleocytosis, mildly elevated proteins, and occasionally we actually even may pick up some hemophagocytic macrophages in the spinal fluid as well. However, it's important to diagnose macrophage activation syndrome much earlier, and the early diagnosis is typically based on the laboratory abnormalities. And at this stage, I would like to ask Dr. Scott Canna to discuss some of the recommendations coming from the consensus conference that was focused on hemophagocytic syndromes in general. Dr. Canna?
Well, thank you, Dr. Grom. That was, as ever, a master class from a master. So it is really my pleasure to present the outcomes of this consensus work, of which Dr. Grom and a number of other experts around the world were a part, to provide some guidance to practitioners trying to make some of the challenging decisions at the earliest stages of this entity that Dr. Grom just described, that we, for the purposes of this effort, called collectively HLH-MAS. Because many times when you're making some of these early decisions, you don't actually know what the underlying cause or causes of the patient's immunophysiologic state might be. And so, on this slide, there's sort of a summary of what's summarized in the paper in one of the figures, where when you have a suspicion for this HLH-MAS entity, you should really be accomplishing three separate tasks somewhat simultaneously. The first is to assess the physiology of HLH-MAS in your patient, both in terms of the degree to which it's present, but also the severity, especially of some of these parameters of organ dysfunction like DIC or CNS involvement. And so, these are some of the lab tests or some of the parameters you might be mentioning and are measuring. And Dr. Grom obviously went through all of these in detail. But at the same time that you're assessing for a patient's physiology and whether they are in a state consistent with HLH-MAS, you're looking for the contributors to that state and recognizing that much in the way that a patient who is in shock related to a number of different simultaneous causes, distributive or cardiogenic at the same time, not to say that HLH-MAS is shock, but that we understand that these immunophysiologic states can have more than one contributor at the same time. And so depending on the age of the patient, the context and geography in which you live, you'll be working them up for a variety of infections, potentially a variety of different malignancies, and other rheumatic or inborn error of immunity diseases, or even some metabolic diseases. And so you're assessing for the physiology, you're investigating the varied contributors to that physiology, but you may also be initiating treatments. Those treatments might be supportive care, and really our recommendations were to follow the supportive care guidelines for that arose out of efforts like the Surviving Sepsis campaign, with blood pressure support, fluids, other parts of those shock guidelines. At the same time, you might be providing empiric antimicrobial therapies on the supposition that a patient might have an infectious contributor to their HLH-MAS state. And you may be providing prophylaxis against deep vein thrombosis or iatrogenic infections or those kinds of things. If your patient looks to be having a severe flare or is not moving in a good direction, even without knowing what the contributors might be, often we will choose to initiate some sort of what we call empiric immunomodulation. The literature would suggest the most well-established and effective method of providing that is through glucocorticoids, anywhere from what we would consider to be a moderate dose, on the order of 2 to 4 milligrams per kilogram of methylprednisolone per day, which is about equivalent to what the dexamethasone dose in the HLH 94 protocol would be, all the way up to what rheumatologists use with some frequency, like a pulse dose. Recognizing that glucocorticoids in the short term can be very effective, but also quite immunosuppressive and can make it very difficult to establish a malignancy diagnosis. And so in those situations, we and others felt that it was appropriate to consider the use of other medications like anakinra or IVIG. These guidelines were presented, were created sort of in the era before we really had data on some of the newer agents like interferon gamma blockers or JAK inhibitors. Importantly, as you continue reassessing your patient, once you've sort of latched on to a confirmed etiology, regardless of it, there are a number of guidance documents that this guidance document that we put forth links to guide your choices at that point, because the treatment for, rheumatic disease-associated HLH or MAS is certainly going to be different than that for, a viral or EBV-driven HLH or a primary HLH or even malignancy-associated. And so the specific decisions in those contexts should really be part of a context-specific therapy. So as part of this effort, we tried to summarize some of the lab tests that are frequently used and the biology that underlies the interpretation of those lab tests. And so many of these patients are going to be getting multiple blood counts where you'll be looking for cytopenias. And Dr. Grom adroitly summarized the mechanisms at work in those cytopenias, both consumption and sequestration by enlarged organs. Looking for evidence of liver dysfunction, not just the liver function test, but things like triglycerides, which we now understand to be a result of inflammation inhibiting this hepatic lipoprotein lipase. And even though we consider albumin to be a liver function test, in this situation, we tend to use it to assess the degree of capillary leak that a patient might be having. Audience probably doesn't need an introduction to assessment of tests for coagulopathy, but things that you want to be assessing not merely at diagnosis, but assessing the trends of those markers over time. And then, of course, a variety of inflammatory markers, both general things like C-reactive protein, markers potentially of some more specificity for this physiology like ferritin. The sedimentation rate certainly can be elevated. We're used to it being elevated in inflammation, but with consumption of fibrinogen, the sed rate can be falsely depressed. And so a dropping or inappropriately low sed rate is something that should be a bit of a red flag. And we address some of the more specialized biomarkers that are not universally available across the globe, but are increasingly helpful in both diagnosing and monitoring patients, including markers of T-cell activation like IL-2 receptor, CXCL9, which Dr. Grom mentioned is a great biomarker of interferon gamma activity, and IL-18, which is an incredibly specific biomarker of the physiology associated with specifically macrophage activation syndrome. So if you have an MAS diagnosis in a patient with a rheumatologic condition, we mentioned that your suspicion may be raised by a low or falling or inappropriately low sedimentation rate, other signs of consumption like low platelets or rising D-dimer, or some of these other features that are not unique to MAS, but are part of the whole HLH MAS physiology, cytopenias, liver dysfunction, hyperferritemia. So as an effort to try to create classification criteria for when has a Stills or systemic JIA flare, crested into the territory of macrophage activation syndrome, there was an effort, again, that Dr. Grom was very much part of, to try and set some guidelines, and these are set forth here. So a patient who has been febrile and has known or suspected systemic JIA with a ferritin cutoff and at least two of these other features, which are certainly shared with the HLH criteria, can then be said to have, in that moment, macrophage activation syndrome for the purposes of both diagnosis, but also as we try to establish clinical trials to investigate some of these newer agents. So there are no FDA-approved medications for MAS currently. Certainly, a number of agents are under investigation. But regardless, just because your patient has a rheumatologic disease doesn't mean that there's not an infectious trigger. As I mentioned, multiple contributors are typically the rule, not just the exception in HLH MAS. So a reasonable infectious workup for things like EBV, CMV, or other viral triggers, that, especially if they can be treated with antimicrobials, in some cases IVIG, is an important part of the workup and initial treatment. Historically, the treatment for MAS has included sort of broad immunosuppression, including moderate to high doses of methylprednisolone, as we discussed. Historically, cyclosporin A has a strong body of literature, tends maybe not to be used quite as much in the current era at tertiary referral centers, in large part because we have other agents that are maybe a little less nephrotoxic. And I think that we are re-emergently appreciating the role for either short courses of or lower doses of etoposide, which may be a potent inhibitor of those hyperactivated CD8 T cells that Dr. Grom mentioned. And obviously, as you're doing this, you're going to be monitoring the inflammation and the tissue damage of HLH and MAS. We've mentioned anakinra and other IL-1 blockers like canakinumab, which are certainly effective in systemic JIA, and at least for the IL-1 blockers, a strong body of literature that they're effective in as part of the treatment regime for MAS. And I think that we are learning more and more about other biologic or other targets for MAS, including blocking interferon gamma. So at this point, we were going to go through some cases. We've had a request within the audience questions to go through at least some of these questions prior to going through the cases. Is that all right with you, Dr. Grom?
Yes, I think that the first question is about whether HLH or MAS can occur when the underlying rheumatologic disease is in remission. The answer is absolutely yes. As an example, if you look at the clinical trial of canakinumab in systemic juvenile idiopathic arthritis, there were many cases of MAS that occurred in the trial in patients whose underlying SJIA was completely controlled by canakinumab. And in essentially all of those cases, the episodes of MAS were triggered by viral illness. The second question was about the hyperreactivity to interferon gamma. We certainly see it in systemic juvenile idiopathic arthritis. We did look at some other rheumatologic diseases. Occasionally, we would see it in lupus, but really it's not to the extent that we observe in systemic JIA. So at the moment, our impression that it's sort of this highly exaggerated reactivity is a feature that is specific to systemic JIA.
Although I might add, some of the recent investigations in MISC suggest that the response in terms of CXCL9 elevation to, even modest amounts of interferon gamma might be a bit elevated. And so this could be a feature of sort of cytokine storm or hyperinflammation more generally, or it may be a specific feature of systemic JIA MAS. And I think hopefully, time will tell as we're able to look at more different patient scenarios and their monocyte responses. The last question in the chat before we get to cases says, can you talk about atypical presentation of MAS-like picture in adults? Can patients present with an incomplete syndrome? My impression is certainly yes. I am a pediatrician, but we increasingly have been managing or helping to manage patients well into their 30s and 40s. I would say that every patient's picture is incomplete until it becomes complete. And I think as we improve our recognition of these syndromes, an appreciation for not just whether a patient ticks the boxes of the criteria, but the trajectory of their progression. They may not have platelets that are below 181 yet, but if they've dropped from 600 to 200 in the last day, that's a pretty strong suggestion that the patient's headed in that direction. I think anytime you're dealing with a different age group, you have to think about other contributors. And certainly in adults, malignancy-associated hyperinflammation is a much more common concern. And we've certainly had a lot of patients where the presentation looked consistent with stills, and only after many weeks to months of really intense investigation did we identify a lymphoma. So, I think you always want to have your radar up for other contributors outside of, anchoring on simply this is a rheumatic flare of MAS. Anything to add on that one, Dr. Grom?
Yeah, I agree. I think the clinical presentation of the MAS itself is probably the same. The differential diagnosis is different. And for that reason, some of the diagnostic approaches would be different as well.